I'm Dr. John Iskander. Welcome to CDC Beyond the Data. I'm here today with Dr. Indu Ahluwalia, Chief of CDC's Global Tobacco Control Branch. Welcome.
Thank you.
So Dr. Ahluwalia, about 6 years ago, we produced a public health grand rounds about global tobacco control. Can you bring us up to date about, first of all, what is the global burden of disease related to tobacco, and are we making progress in controlling that?
Certainly. We know about 1 billion people in this century will die of tobacco smoking. And of those, about 700,000 per year die from direct tobacco-related tobacco use, and about 600 or 890 die from secondhand tobacco smoke, and these are people who don't smoke themselves. So burden continues to be quite large. And in terms of, when we think about the CDC's role, we are able to help countries make critical decisions, and international organizations use the data that we collect through our surveillance systems to monitor what is going on in terms of both the burden of tobacco use as well as the solutions the countries have undertaken and potential impact of that. A recent report that was released by the World Health Organization indicated that there's certainly progress in terms of globally there's a reduction in tobacco use. And what we find is, within that report, it also had some alarming things, that the rate of decrease among low and middle income countries is slower. So we still have a lot of work to do. And we think that the data that we generate and we help countries to translate into actionable policies and programs are critical to moving the needle forward.
So clearly we have ways then to monitor different aspects of smoking and tobacco globally. Can you tell our audience a little bit about how we monitor everything from smoking to exposure to advertising?
Sure. So the CDC Global Tobacco Program, this is where the global tobacco surveillance system is housed, and we have 3 different components which we are able to work with each country side by side to implement. We have the Global Youth Tobacco Surveillance, which is GYTS, active in 188 countries. It is the largest surveillance system, continues to be so, and it is targeting kids who are 13 to 15 years of age and in schools. We're very proud of our system. And then we have the GATS, which is the Global Adult Tobacco Surveillance, which is active in about 34 countries, and it targets adults 15 years of age or older. And it covers about 70%, or it represents 70% of the world's population and about 75% of the smokers in the world, which is quite remarkable. The third is we have a set of tools called Tobacco Questions for Surveys, which are systematic, standardized set of questions that countries can use and integrate in their ongoing surveillance systems. And with the 3 components, we feel that there is a sustainable way to monitor tobacco globally. And our role is to work with countries to figure out what their needs are, and then we work side by side with countries' ministries of health, ministries of education, even the global partners are at the table. And what we do is we systematically make sure the training is standardized, the data collection is standard, so we can compare the data across time and across countries. And that's an important part of having a surveillance system that contributes to the landscape.
So, and you shared with me earlier some examples of countries that have used that monitoring and surveillance as part of their tobacco control strategies. I wonder if you could maybe just share one of those examples with us now.
So, using the data for tobacco control, I think, otherwise we're just groping in the dark, and countries are very eager to have data. And I will share an example of Uganda. They had first wave of data, and they passed a National Tobacco Control Act in 2015. Prior to that, they were the country who used both GYTS and GATS data quite effectively to rally the troops, so to speak. They used the data to educate and mobilize their stakeholders, so there was support for passing the law. There are other examples of countries that have had multiple waves of data. India comes to mind since they just released their data very recently. And India saw quite a great decline in tobacco from the first survey, which was done in 2009, 2010, and the most recent survey, which was completed in 2016, 2017. And part of that allowed India to know that the law that they passed under their Food Safety Act in 2011 banned gutka, which is a flavored tobacco with areca nut. And the state subsequently in India adapted some of that law and stronger provisions to ban other flavored products that contain tobacco. And what the data really showed for India was that there was a decline in smokeless as well as combustible tobacco products. Because there was fear, of course, that you ban smokeless tobacco and there might be an increase in combustible, and that didn't happen. So what that really demonstrated to India and the states and others watching this very closely is that when a strong legislation is passed, there is an impact, and our data were critical in measuring that impact.
So, yeah, very important, of course. My understanding is Asia is now home to half of the world's smokers, so very important to hear of that substantial progress being made in India. I think a lot of our viewers may wonder about the changing landscape of tobacco products. We have e-cigarettes now, but particularly in low and middle income countries, we also have, people may know them by different names, shishas, hookahs, water pipes, other different kinds of products. What do we know in general about use and control of those types of tobacco products?
Sure. I think you bring up a very important point, in terms of the changing landscape. And what's interesting about the global landscape is that, if you look at the data, what they're showing is there's been an astronomical uptake of vaping products like e-cigarettes and e-pens and all their iterations. So there's a very rapid progression in the global market of these products. I think it's anticipated to be reaching 55 million users by 2021, which is only 3 years away from about 7 million that was observed in 2011. So a huge increase anticipated by 2021. And what the other interesting thing about the changing landscape is that when you look at the 10 top global markets for sales of these products, of course, the Western countries are there, but what's remarkable to me is that both India and China are among the top 10 purchasers of these electronic products that are available. And one of the things we find with our, we've been in the forefront in terms of surveillance. Our both GYTS and the GATS surveillance have collected some information from a number of countries about whether the kids are aware of the products and what the use is, and for adults as well. And what we find is there's a high level of awareness. When we look, 20%, upwards of 20 to 95% among kids, similarly among adults. It varies by country, of course. And the use is still low, which tells us that it's very possible that as the cost of these products goes down and marketing is very aggressive, as we see, that there is potential for these to increase worldwide.
So certainly something that will need to be monitored going forward.
Absolutely.
So you gave a couple of examples earlier of India and Uganda. Both of those involved laws. There have been a number of types of laws and policies that have been proven to be effective in decreasing tobacco use and harms from tobacco. Could you briefly review what some of those are?
Sure. So most of the countries are signatories to the World Health Organization's Framework Convention on Tobacco Control. And with that comes a set of guidelines that countries can follow and reporting requirements. And in addition to those guidelines, there's the empowered demand reduction measures. in those demand reduction, these are proven strategies that countries can adapt for their tobacco control efforts. They include everything from monitoring to raising taxes on tobacco products and monitoring the tobacco industry, for example. So all of those combined provide guidance to countries on how to measure what's going on. That's of the Empower is monitoring tobacco surveillance and policies, and then also to enact programs that allow them to tackle different, anything from legislative to monitoring of the industry, raising taxes, to protecting people from secondhand smoke in public and other places, having legislation and other efforts, and helping people to quit. Another very important aspect of, as the landscape changes, we need to have services to assure that people who want to stop can.
Dr. Ahluwalia, going forward, really, what is the bottom line about global tobacco control and monitoring?
We know surveillance is essential. Data tell us where we are, where we need to go, and what we've done well. And I think in terms of millions of lives are at stake, and we have an opportunity to save them. And in fact, 100 million lives is the goal for tobacco control. And our data will be really important to measure measure where we are, and what gets measured gets done.
Thank you very much, Dr. Ahluwalia, for your work and for being here with us today.
It's my pleasure.
Thank you for joining us for Beyond the Data.
If I had to say something directly to HIV, I would have to say that you do not define me. That's what I would say. I would tell a person who is HIV positive, either newly HIV positive or a person who might have been in care before, just all the wonderful advances that have been made when it comes to HIV/AIDS, especially HIV, and that actually it's no longer a death sentence that it used to be. When I was first HIV positive, I was full-blown AIDS. The time was very different. The medicines weren't as good as they had now. I weighed 70 pounds. When I first saw myself in the mirror, I cried. Again, it was different back then, but it was very devastating for me. I first got into medical care because they didn't really know what was wrong with me. The HIV was hiding with another symptom and condition. So I kind of ended up in an emergency room situation. And finally, after that, a doctor from University of Miami came in and did the work and diagnosed me of what it was. And since taking my HIV medicines, I've maintained really good numbers, both with my CD4 and my viral load, which is undetectable. And since then, I've stayed in care and remained in care. If I was talking to a person who was just recently diagnosed and they were probably very afraid, I would want to break it down in simpler terms as to what the viral load is as far as the amount of HIV per unit in your blood. But also I'd want to be a little bit more compassionate and explaining to them that it's going to be okay. It's not the end, it's just a new way of doing life, and it's not a death sentence, and that they're going to be okay. Well, as a transgender woman, it's important to me because when I was first diagnosed, accessing care was very difficult for me. And a lot of the work that I do is helping or setting up at conferences free HIV screenings, STD screenings, and things like that across the country. As a person with HIV, living well means just on every level, my mental health, my physical health, eating right, exercising, living life knowing that I'm going to live, and that just making the most of it. HIV treatment works. Get in care, stay in care, live well.
Our job at the Division of Global HIV and TB at CDC is to end epidemics. We work on HIV and we work on TB. TB and HIV are related. They co-occur in significant numbers of people. Having HIV means that you are greater susceptibility for acquiring tuberculosis. One of the things that's really important, part of our identity at CDC, is the use of data to depict epidemics, to identify public health problems, and to guide the solutions that we implement. Our epidemiologists, our medical officers, our public health advisors, and other practitioners are actively working to inform the way that we plan future programs, to monitor the success of those programs, and to make sure that we achieve the greatest impact possible at the greatest value. I get to work with the absolute best people who wake up every day and are excited about the commitment that they make to public health, whether it's HIV or TB, and doing better for the global community. There are tens of millions of people living with HIV. 10 million people each year who develop active TB disease. The co-occurrence of these problems reflects a significant concern. We have an unequaled opportunity to make a difference. We've got the people, the resources, and the tools that are necessary to make an extraordinary contribution. I'm excited every day about coming to work and rolling up my sleeves with my coworkers and figuring out how to make that possible.
Youth violence occurs when young people intentionally use physical force or power to threaten or harm others. It is a public health problem that is preventable. Bullying, fighting, threats with weapons, and gang-related violence are all forms of youth violence. This problem affects thousands of young people, their families, and communities each year. It impacts all genders, races, ethnicities, households across income levels, and communities, including urban, suburban, rural, and tribal areas. Youth violence happens every day. Every 24 hours, about 15 youth are victims of homicide. Over 1,300 youth are treated in emergency departments for injuries from physical assault. It is important to identify the things that put people at risk for experiencing youth violence. Some risk factors include previously experiencing violence, harsh discipline at home, social rejection, poverty. The good news is youth violence can be prevented. Factors that protect young people from violence include having problem-solving skills, positive relationships with adults, and a commitment to school. There are 6 strategies that help keep youth safe and healthy. They include promote family environments that support healthy development, provide quality education early in life, strengthen youth skills, connect youth to caring adults and activities, create protective community environments, intervene to lessen harms and prevent future risk.
Some say e-cigarettes aren't dangerous,
But science shows nicotine can harm teens' developing brains.
no matter how they're exposed.
Let's do an experiment to find out.
Here's a teen who won't be using e-cigarettes.
Now we need one willing to risk their brain development.
Anyone care to volunteer your kid?
Anyone?
I'm Dr. Vivek Murthy, U.S. Surgeon General. Your kids are not an experiment. Protect them from e-cigarettes.
The Hospital Preparedness Program has taken the lead on hospital preparedness to help keep our nation's communities healthy and safe when disaster strikes. This year, HPP turns 15. Let's take a look back. Disaster can strike in any community, and healthcare organizations, as part of a community's response team, need the resources to respond. In 2002, HPP began helping hospitals purchase these resources. Life-saving equipment like mobile health units, communication systems, and ventilators, many of which are still used today. But to keep our communities prepared, we need more than just resources. As an essential member of the team of frontline providers, hospitals and clinics need to collaborate and coordinate among the many different response organizations that keep our communities healthy and safe. This is why HPP supports healthcare coalitions. These are groups of healthcare and response organizations that work together in their communities to prepare for and respond to emergencies. Today, HPP provides funding and guidance to over 470 healthcare coalitions across the country. HPP has established a nationwide treatment network for Ebola and other infectious diseases, making us more prepared than ever for future disease outbreaks. Develop guidelines that describe what the healthcare system must do in the next 5 years to prepare for disasters, and enabled life-saving care during emergencies like the Boston Marathon bombings and in natural disasters like Hurricane Harvey. HPP helps patients receive the right care at the right place at the right time. Strengthening the healthcare system to keep our nation healthy, safe, and prepared isn't easy, but it's our mission as part of a comprehensive regional disaster health response system. HPP will continue to improve the nation's readiness and responsiveness. ASPR, Saving Lives, Protecting Americans. Produced at U.S. taxpayer expense by the U.S. Department of Health and Human Services.
It was very frightening at first. We didn't know how strong the hurricane would become. And then Hurricane Irma that landed on September 6th was a Category 5. And then 2 weeks later, Hurricane Maria, another Category 5. There was a lot of damage, of course, from both hurricanes. And it was difficult to try to figure out what to do, even though we had plans, because we did not expect the type of devastation that had occurred throughout the entire territory.
After a hurricane or tornadoes or a major storm impacts an area, there are a lot of unknowns that the Department of Health and leadership don't know about. And so a CASPR was designed to go into the community and quickly gather information about that community's needs.
The acronym really does tell you what a CASPR is, and it stands for Community Assessment, Public Health, Emergency Response. So we're surveying the public, that makes sense. And then the public health emergency, in this case, were 2 Cat 5 hurricanes. And public health response is what has been done, where is the community at now, and what still needs to be done.
There was water all in the whole house. They only had to put everything out because of the mold and all the water keep coming in before I get the tap up. But since we have the tap holding up, everything is going okay.
Great. That's really good to hear.
Yeah, we had mosquitoes after the hurricane but now they're just like not much.
At its core, CASPR is really about knocking on doors and interviewing members of the household about what their needs are. To do that, we need some consistency and we need some systematic way of selecting which households.
We come up with our objectives, our sampling frame, our questionnaire, and once we're done with all that preparation, we go into the field and we do a just-in-time training for the team members. And this covers things like logistics, safety. The teams will then go out into the field that afternoon and potentially the next day for about 10 hours of data collection. Once data is collected, we have about a day to analyze it, interpret it, write a report, and get it to the community leaders. And that way, the information is used right away.
The data that we get from CASPR, we spread through many different departments. Our preparedness department, our epidemiology department, our maternal, child, and health departments, including our women, infants, and children's department, are able to get the data that we need so that we can arm the public with knowledge and with equipment.
And this CASPR that we're doing now is 6 months post-hurricane. The main issue that appears to be happening right now is mental health and some post-traumatic stress. Once we analyze the data, then we can do targeted response or recovery efforts to manage that or help improve that.
Other conditions that we need to be concerned with are the areas in vector-borne diseases or mosquito-borne illnesses. We have emerging infections that we're seeing in our territory that will continue to increase, especially with the environment after the storm and limitations in places where we can actually provide vector control.
So it's a really quick and inexpensive, it's a very flexible tool. It was designed for after disaster use, but really has broadened a lot more. So you can use a CASPR for the response efforts. You can use it for recovery efforts. You can use CASPRs to prepare for an emergency, to see how the community is.
A CASPR is really a locally driven endeavor. It's simply a matter of federal partners bringing in some expertise and some information to empower and enable the local health department to perform the CASPR independently.
CDC has been a major partner for our operation and building capacity. We really appreciate them because a lot of work that I have done, I wouldn't have been able to be as effective without their assistance and support.
And this program, going out there and listening to the pulse of the community, hearing what they say, and bringing it back to us as the lead healthcare agency. Whatever we can do, we're there. We're responsible for the community, and that's what we're doing.
When I'm recommending the flu vaccine to a patient, I usually want to make a strong recommendation. And if they seem hesitant at all, I want to have a conversation about what their concerns are. And many times the concerns that they have are not fact-based. Many times they've heard myths, like the flu vaccine causes the flu. Nothing could be further from the truth. So it's helping patients understand how the vaccine works.
The life I lead is both adventurous and it's very fulfilling. I'm Ty Reedhead. I'm the area director for the Phoenix Area Indian Health Service, and I work here in Phoenix. I always loved taking care of animals and people. I had gone to medical school at the University of Colorado on an Indian Health Service scholarship. And for my 2-year service obligation, I chose the White Mountain Apache tribe in northeastern Arizona. I could really feel the difference I was making, so I stayed 12 years. From the beginning of my IHS career, I had been a U.S. Public Health Service commissioned officer, which has been another way of broadening my experience. I've worked for the Indian Health Service for over 20 years now, and I enjoy all of the passionate people that I work with, and I feel part of the team. I'm using every skill I've learned. It's exciting and challenging to keep improving and innovating. The Indian Health Service fits well into my work-life balance. My love for rodeo gives me an opportunity when I'm not at work to get out and spend time with my family. What could be better? I'm Ty Reedhead, and I lead improvement in the Indian Health Service. I'm a doctor and a cowboy, and I am HHS.
Produced by the U.S. Department of Health and Human Services at taxpayer.
Millions of Americans
have hepatitis C, but many
don't know it. People born from 1945
to 1965 are 5 times more
likely to have hepatitis C. People can live for
decades without symptoms. Left untreated,
hepatitis C can lead to liver cancer.
But treatments are now available that can
cure hepatitis C.
Talk to your doctor about getting tested.
We got
tested.
It could save your life.